Good evening, everyone. Welcome. Thank you so much for coming. So this is our, oh my goodness, umpteenth year of doing citizen science seminars. We've been doing these for about 8 or 9 years now. And we are kind of branching out a little bit, looking at not only environmental and ecological issues and concerns around our area, but also health, medical, and just anything that I think just needs to be addressed. And so I was very pleased to be introduced to several folks in our area that wanted to do the first annual Bay Breast Cancer Awareness Symposium. And so I'm going to make a couple of introductions in just a moment for those individuals, but I just want to let y'all know how wonderful this is, and I really appreciate those of you that volunteered to help us put this on, our sponsors, and our speakers. So first of all, I want to make sure I introduce myself. I never do that. My name is Carrie Fioramonte. I am an associate professor of biology here at Gulf Coast State College. And so I also would like to let you guys know, for your comfort, the restrooms are over here in this breezeway, in this corner, as well as the staircase for safety. And I also want to make mention, we do these citizen science talks monthly, and next month we are actually going to have our very own Dr. Jessica Edwards from Natural Sciences, and I'm going to read this part because she's a physicist. She is going to talk about radio astronomy observations and how they reveal remarkable molecular, that's bonded atoms, content in regions of space that were once thought to be atomic. So that's like single atoms, right? So wow, right? So that is going to be happening in early November. Not quite sure of the date yet, trying to find out when this room is available. I'm thinking the 9th or the 16th. And I'm going to let you guys know about it. Should be really intriguing. And so one other thing I also want to mention, a shameless plug for an organization that I am on the board of, Bay County Conservancy, also Northwest Florida Land Trust Organization. I wanted to just kind of put the word out. We are looking for a preserve manager. Bay County Conservancy buys lands all around our area and for conservation and preservation efforts. And we are looking for someone to help us manage those lands. It is a part-time job, but it's a pretty good paying gig. So if you are interested, and even if you're out there, just anywhere in the community, I would be very happy if you would reach out to me. Again, my name is Carrie Fioramonte, right here at Gulf Coast State College. And so I think without further ado, what I would like to do is announce our first we're going to do the MC part, right? So I want to make sure to introduce my first guest and MC, Ms. Jessica Foster. Many of you may already know Jessica. Jessica is going to share some personal experiences with us about her own battle with breast cancer, and then she's going to help us to kind of kick it off and introduce the rest of our speakers, as well as our invocation and singing guest, Nisa Wilkins. All right, so take it away, Jessica. Thank you.
Hello, everyone. Thank you so much for coming out tonight. Before we get started, I do want to tell you about my journey with breast cancer. But before we get started, I do want to turn it over to my coworker, Miss Nisa Wilkins, and she is going to give us the invocation because I think that we need to start off with a prayer tonight. So, Nisa, if you will begin with that.
Thank you, sweet Jessica. Let us pray. Heavenly Father, thank you for the opportunity to spend this time together, for the chance to share vital information about a disease that has affected all of us in some way. Hopefully this information will help save lives. Thank you for precious Lynette, who works tirelessly to help any person navigating through a breast cancer diagnosis, for all the long hours spent making this symposium a reality, and the businesses and individuals who were instrumental in making it happen. Help us to continue our mission to make sure no breast cancer patient walks this journey alone. You are there beside them, and you have equipped us to walk alongside them as well. You have taught us that faith as small as a mustard seed can grow into an amazing, strong tree. Today, we give you our little mustard seed of faith. We place it firmly in the ground of your word. We water it with your truth. The warmth of your love will make it grow. Today, we ask by faith that you bring healing from this cancer and that there may soon be a cure. We place our trust in you. The Bible tells us in Joshua 1:9, have I not commanded you, be strong and courageous. Do not be frightened. Do not be dismayed. For the Lord your God is with you wherever you go. Even if that ends up being the dark road of cancer, you will be with us. Exodus 14:14 says, the Lord will fight for you. You need only to be still. Please bless this gathering and every home represented here. We thank you for the food that has been provided, and we pray that you bless it to our bodies and us to your service. In your holy name we pray. Amen.
All right. Thank you so much, Nisa. So I'll start by introducing myself. My name is Jessica Foster, and I'm the morning and midday anchor at News Channel 7. And I'm a breast cancer survivor. Going on 4 years now as a breast cancer survivor. So that is something to celebrate for sure. But I want to tell you a little bit about my journey because I hope that it inspires you to pay attention to your own body and to do those things that we are always told to do. So ladies, how many of you do a monthly breast self-exam? Are you going to be brave enough to raise your hands? Okay. All right. I see the doctors in the room do their monthly breast self-exams. That's wonderful. You know, we're told to do our monthly breast self-exams. My mother always told me to do that. She always told me to wear lipstick when I go out and to do my monthly breast self-exams. And I'm a good daughter, and so I listened to my mom. So I would do my monthly breast self-exams. Well, one month I noticed something, and I felt a lump there. And so I called my doctor, and I went to my doctor, and he said, you know, it's probably nothing, but let's go ahead and get a mammogram and see what's going on with it. So I did the mammogram, and it ended up being a benign cyst. It was no big deal. They drained it, went away, and I'm like, whew, okay. Well, I was worried for nothing. And when I went back to the doctor, he said, yeah, that's great. You have fibrocystic breasts. We see that a lot, especially dense breast tissue in young women. But since we got your baseline mammogram, we can go ahead and start doing your yearly mammograms. I was 30 years old at the time. So really not at the age where you would typically start your mammograms, especially because I didn't have a family history of breast cancer. But I said, okay, well, I'll do my yearly mammograms. That's fine. I've always been kind of a proactive person. And so Dr. Weintritt-Davis, who you will hear from a little bit later, she would read my mammograms every year. Well, year after year, it was fine. Nothing showed up on the yearly mammogram. And I remember thinking I was so busy, and you know, I'm a mom, and I was like, why am I going every year? And I'm not even at the age where I need to have this. And I almost didn't go. This was 5 years after the initial mammogram. And then I did a story with a breast cancer survivor. And she was talking about how she's so glad that she did her mammogram because it caught the breast cancer early. And I was logging my interview, which we do as reporters, and I was hearing her say this. And something inside me said, I need to call and get my appointment for my mammogram. I know it was the Lord speaking to me. And I picked up that phone, and I called Bay Radiology, and I said, hey, I really need to get in for a mammogram today. And they were like, well, wait, actually, we had a cancellation, so you can come on in. So I went to my news director, and I said, hey, I have an appointment that I've got to go to. And so I left, and I went to get my mammogram. It was like some force was just pushing me to go get my mammogram. Well, I got that mammogram, and they wanted another image. And I was like, oh, it's just because I have dense breast tissue, like all young women do. And Dr. Weintritt-Davis actually pulled me back into her office. And she said, okay, do you see these tiny calcifications here? This was your mammogram a year ago. This is now. This wasn't here before. She said, so I would say we could go ahead and biopsy that just to make sure. Most of the time when we see these tiny calcifications, you know, it's not cancer, but if you want to be extra careful, we can do that biopsy. And those tiny calcifications were clustered together. And I said, you know what? I want to do the biopsy. So she actually did the biopsy the very next day. And I remember all that weekend, I just remember just feeling so anxious to get those test results. And as a reporter, I was like, I could probably call and get them earlier. And, you know, the doctors never want to tell you anything until it's time for your appointment. I just remember, oh my goodness, I was like, somebody's got to tell me early. I cannot wait until Tuesday to find out the results of this. I don't know if you know this, Dr. Davis, but I found out which lab was processing it, and I called to see if maybe they would tell me earlier, and they said, well, we don't release that to the patients. So, yeah, I don't know if I ever told you that, but that's how anxious I was. So anyway, I went in for my appointment on Tuesday with the breast specialist, and he said, I'm sorry to tell you, but you have breast cancer. And I remember looking at him, and I said, well, we've got to make this okay because I have a daughter, and I have to be there for her. And he looked at me, and he said, we caught it early. And this is going to be okay. Most of it was inside the duct. There was 1 millimeter outside of the duct. 1 millimeter. That's how tiny it was. He said, you have a couple of options, especially when you catch this breast cancer early. You can have a lumpectomy with radiation or a mastectomy. He said, you don't have a family history of breast cancer, but you're young. I was 35 at the time. He said, so let's do some genetic testing just to see. I really didn't think that the genetic testing would come back as anything because, again, no history of breast cancer in my family. Well, the genetic testing came back, and I was positive for the BRCA2 gene, which is a gene that makes your probability of having breast cancer higher. You'll hear more about this with some of our speakers a little bit later on. And that BRCA2 gene did not come from my mother. It actually got passed on from my father, who later developed prostate cancer at the same time that I was going through breast cancer. That gene also puts you at a higher risk for prostate cancer. So very unusual circumstance. But because of that, I decided on a bilateral mastectomy with reconstruction because that would lower my chance of recurrence. And with that BRCA2 gene, you are at an increased risk of having breast cancer in the opposite breast as well. So I say all this to say you can never be too cautious. You know your body. You know your body more than anyone else. Don't be afraid. If you have that feeling in the pit of your stomach that something's not right, I just urge you to act on it. And I know as women, we often neglect ourselves because we are busy with our families and we have children, we have a spouse, and we take care of everyone else, but sometimes we neglect ourselves. And I just urge you to always, always put your health right up at the top because without that, you don't have anything else. And so I went through the surgery. I'm thriving, and as difficult as that journey was, and ladies, it is a difficult journey. It is. I'm not going to sugarcoat that. But as difficult as it was, I knew that there was a reason that I endured that. And it's because I have a voice, and I want to use that voice to encourage other women and to show you that there is hope. And because of events like this, we're going to get the word out there. We're going to let people know about all of the advancements, the research that is going into this. And I do hope and pray that one day we will live in a world without cancer. But until then, I just thank all of the medical professionals and everything that they do in our community. I stayed right here in Bay County for my treatment, and I'm so glad that I did because we caught that breast cancer so early. I did not have to go through chemo or radiation, but that's how I found my breast cancer at a very young age. And Dr. Weber, my oncologist, just walked in as well. Hi, Dr. Weber. He's taking care of me too. I love seeing all of these wonderful faces. Again, we have a wonderful medical community here in Bay County. So thank you all for allowing me to share my story. Thank you for coming, because you're here tonight, that shows that you care. You care about your health and you care about this community. So thank you so much. And Nisa, she has such a beautiful voice, and she has the pleasure of, well, we have the pleasure of listening to her sing this evening. So thank you so much, Nisa. Lisa, and we just want to remind everyone that if you haven't gotten food, that is provided. So go over there and get your food. And also, thank you to Culligan for providing the water, K-Halls for providing the food. And oh my goodness, have y'all tried that chicken salad? Okay, some people said not yet. You got to get some because it is delicious. But we have a wonderful array of speakers for you tonight. And our first speaker, I'm going to actually grab right here. I know, I might need the glasses, right? Michelle Batista will be talking with us this evening. She's going to talk about risk factors, the need for updated guidelines. Also, she will be talking about the BRCA1 and BRCA2 gene that I talked about earlier. And her specialty is hormone and wellness. She's got a wonderful presentation ready for us. So if we can have Miss Michelle Batista join us. Yes, Nisa speaks so highly of the work that you do, so thank you for being here this evening.
Thank you. Maybe this is it. Oh, I guess that's it. Okay, I do have it. Okay. Well, good evening, everyone. I'm Michelle Batista. I am a nurse practitioner here in Panama City. Born and raised here in Panama City, which is unusual, maybe a little bit. Moved away for a number of years and came back to help take care of my grandmother when she got old. And so I opened a hormone therapy clinic here in Panama City. So I primarily treat men and women, even younger men and women with hormone imbalance. Breast cancer period, is a kind of a really interesting topic for me and something that I take very seriously. And so we're going to talk a little bit about cancer, particularly breast cancer. As some of you may know already, throughout the years, lung cancer has been the most common type of cancer that we see until this year. For the first time, breast cancer has surpassed lung cancer as the most commonly diagnosed cancer in the world. So it's not just us, it's everywhere. So on average, about 11.7% of cancer diagnosed around the world is breast cancer, and it edged out lung cancer, which is at about 11.4%. So the first thing we want to talk about is what is cancer. And so this little slide basically says that it's a disease in which the cells in the breast grow out of control. And that's going to be the case with any area that we see cancer, whether it's lung cancer or kidney cancer or whatever. It's basically cells that are supposed to grow one way and decide to grow a way that's not good for us. There are different types of breast cancer. And they're kind of named based on where they're located. We can have breast cancer in the duct, and we can also have breast cancer that's in the lobe, within the lobe. And we can also have some connective tissue cancers in the breast, but that's not very common. And I'm not sure if our oncologist tonight will discuss any of those kind of things. Most of the breast cancer that we see in women occur in the lobe. And I think about 85% occur in the lobe of the breast, and 15% in the milk ducts. In men with breast cancer, it occurs more often in the duct, in the ductal area in the milk duct. Cancer can spread outside of the breast, and we call that metastatic breast cancer when it spreads outside the breast, and that spreads through the blood vessels or through our lymph nodes. Cancer can also be classified as either being hormone positive, and the hormones we talk about is estrogen receptor positive, progesterone receptor positive. It can also be HER2 positive, that we see a gene mutation there. And it can be triple negative. It can be a type of cancer that's not related to hormones, either estrogen or progesterone, and may not be HER2 positive. I think that's the one the oncologists dislike the most. Because we can't say, oh, this is why you got it. You just kind of got it. So I'm sure the oncologists will talk about a little bit more of that. Other numbers. This year it's estimated that about 1.8 million new cases will be diagnosed in the U.S. 606,000 people will die from cancer And again, it's the second leading cause of death in the United States is cancer. Well, today the most common cancers, we listed them here. Breast cancer is number 1, lung, prostate, colon rectal, and skin cancer. The chance of getting breast cancer by the age, that's one of the risk factors of breast cancer. Of course, we all know the number 1 risk factor is having breast or breast tissue. So that puts us girls right up at the top. However, by age group, we see also, as we age, the risk for developing breast cancer increases. We see that women that are over 75, they have a 27% chance of getting breast cancer. There was at some point an idea that women didn't need breast mammography after age 65 or 70, but that standard was kind of put in place when women died around 65 or 70, okay? Now that we're living longer, it's time for us to change that thought that it's not necessary to do breast cancer screenings on women over 70 because, heck, more than a quarter of it occurs. Breast cancer occurs in women that age. 23% of cancer develops in women that are under 54. We are seeing more breast cancer in younger women under 40. Not quite sure exactly why that's happening, but we are seeing more of it. And it tends to be a little bit more aggressive in younger women. And more likely, you'll see more often it's in younger African-American women that we see a higher number of cancers at a very young age. By race, this slide is a little bit interesting. We still have more breast cancer showing up in Caucasian Americans, white Americans, women. However, if we compare that to the numbers that we see here for African American or Black American women, we see the rate is a little bit lower, but the death rate is a bit higher. Okay, there seems to be more research looking into why is that happening, and we're doing this genome testing and genetic testing and different things that we're able to do now. And there's a theory that is potentially that African Americans, cancer responds more aggressively in our body. So you may have two people the same age, the same kind of cancer, diagnosed at the same stage, and that Black female will have a little bit higher, still have a little bit higher rate or risk of not making it through surviving that cancer. Another interesting point down here is in India. Now, of course, India, I think it would be a subcategory of the Asian population, but their incidence rate is much lower than ours. However, that is an increase for them. But look at the death rate, about 49%. And that's mainly because they tend to be at later stage at diagnosis. I'm not sure if that has to do with their cultural sensitivity in regards to like undressing and things like that, and getting exams done that way. So, but that's pretty significant. And also for them, 50% of their breast cancer occurs in women under 50. So, and that's something that we need to think about and consider because our population in the U.S. is so diverse. We have all types of people from all different parts of the world that migrate and live here. And so as we work with these patients that have different cultural backgrounds, we need to make sure that we're reminding ourselves as well as our patient that, hey, culturally you're at a higher risk for, cancer based on, racial differences and sometimes cultural differences. Male breast cancer, we get about 2,600 cases a year and about 500 deaths per year for men. I think male breast cancer counts for about 1% of the overall total of breast cancer that we see in this country. Let's see our next slide. Okay, modifiable risk factors. Now these are things that you can change. Okay, and it's been said that making some modifications in these areas can reduce the risk of cancer by about 30%. Okay, so that's a pretty good benefit for us to try to reduce these things that are modifiable. Smoking, of course, probably is a risk factor for almost any type of cancer that we get for the most part. Alcohol, sedentary lifestyle, weight control. People who follow high-fat diets are also people that tend to not have a very good diet when it comes to consuming foods that are high in antioxidants. And so, keeping the body fat under control. Also, the other thing about weight is obese people tend to carry a little bit more, just a low grade of inflammation all the time. They're carrying a little bit more weight, and so it keeps the inflammation in the body higher. And that also produces some stress on the body and the immune system. Medications, we can modify the intake of medications, in particular a lot of times the hormones, synthetic hormones also that we find also in birth control pills, and I'll mention that again a little bit. Environmental pollution, we have those things are toxic to us. Excess exposure to radiation, and sometimes you'll hear a debate about I shouldn't get my mammogram because I'm going to be radiated. Okay, and I think Doc will talk about that. Hopefully, one of our breast specialists will talk about that a little bit. But I do think that we've made every attempt possible to minimize that exposure, and that there are things that we can do. If my patient says that not sure they want to get it because of radiation exposure, I say, well, what we worry about is oxidative stress on the body. Okay, so we can kind of combat that if we do some good heavy intake of antioxidants for a few weeks before your mammogram and a few weeks after. How about we try that? So that's not scientifically proven, but in my brain that kind of probably would work. I don't know, but my brain sometimes is not a good place to be. Stress taxes your immune system. Your immune system is what surveys the body and tells the body when there's a bad cell around. So if I'm chronically stressed and I'm putting this extra burden on my immune system, my body may not be able to fight cancer or even find it like it normally would, as far as our body's being able to survey itself and find bad stuff. There are things that we can't control. We can't control our advancing age. Well, we could kind of control it, but we shouldn't try to control our advancing age. We can't control what race we were born into. And for females, some things like number of years on birth control pills. If you're on birth control pills for a long number of years, that can increase your risk for breast cancer. Women who breastfeed their babies and breastfeed their babies for a long time, if they've been shown to decrease the risk of breast cancer. Age at the onset of your age at the birth of your first child. So women who are having babies at 40 and they've never had a baby until 40, their chance of breast cancer may actually be a little bit higher. Onset of menstrual cycles. When did you start your cycles? Did you start your cycles at 10 years old, and then how long did you have your cycles? Did you go through menopause late? So those kinds of things have some impact on the risk. Family history should have been actually underneath that, but family history of cancers, and family history of cancers is really important. If you have a first-degree relative, that's your mom, your sisters, or your daughter, have breast cancer, your risk for breast cancer increases. But also let me remind you that most breast cancers that we find are not from people that have a family history, okay? But a family history can increase your risk. If you have a family member, a first-degree relative that has male in your family that's had breast cancer, and also, as Jessica pointed out, a male, first-degree male, that's your father, your brother, or your son, develops prostate cancer, it increases your risk for breast cancer up to about 72%, okay? So that's a big deal. So a lot of times we think about, well, I don't have a family history of breast cancer. Think about your family history of prostate cancer as well, okay? And so it's important that you ask those questions. BRCA1 and BRCA2 are genes. We call it, BRCA is for, the BR is for breast and the CA is for cancer. And so there's gene markers 1 and 2. If there's a family history of being positive, either yourself or someone in your family, your risk for breast cancer also increases with that. So there's a population within the Jewish culture, culture that has an increased risk of developing one of these gene mutations. And so they're at higher risk also. In males, one risk factor is still the same as the girls: obesity, overexposure to like cigarette smoking, alcohol, things like that. But Klinefelter's is a genetic disorder that we can see in males where they are born with an extra chromosome that may cause them to produce higher amounts of estrogen. Okay, so male exposure to estrogen as well increases their risk also. When do you start screening? Screening should be started when it's appropriate for the individual. So if you consider the family history, say this person does have BRCA gene positive, we would start their screenings at a much younger age, even as early as 25 years old, because their risk begins to increase after 25 years old if they're BRCA gene positive. Again, those high-risk populations should start screenings earlier. If we say that recommendation is at age 40 for the average adult female, but what's an average adult female in America these days? We're such a mixed population that, you know, it's just base it on what the person has going on in the family. This is not an inevitable fact of life. We're not all going to get breast cancer, okay? And in many cases, we may be able to this can be prevented or detected at the earliest stage and the most curable stage. Follow these simple steps. Following these simple steps can protect you. Know the risk and ask questions. If you don't know the answers, ask questions. Make healthy lifestyle choices and access health care services, including your preventative screenings. That for some cultures, that is the access to health care is one of the critical components that's missing. Some of it sometimes is that they simply distrust the healthcare system, and we need to do a better job of helping them feel more comfortable. So that's just a little bit of a brief on what we're going to talk about tonight, and I think the next person has a little bit more to go into. All right. I think I stuck to my 15 minutes. All right, let me grab my stuff.
She's one of my husband's favorite people. Kept my head from spinning. Our sweet Jessica has to be at News Channel 7 at like 3 in the morning or 3:30 in the morning, and she has to be on the news at 4:30 in the morning. So we told her to get out of here and go home and go to bed and get some sleep. So, so the part of Jessica Foster will now be played by Nisa Wilkins. Thanks, Michelle. That was wonderful. We have Dr. Julie Miller and Dr. Lindsey Weintritt-Davis. We've heard their names a little bit tonight, and they are so knowledgeable about this. They're going to be speaking about symptoms and diagnostics, myth-busting. We hear a lot of myths about breast cancer. We didn't get Dr. Weintritt-Davis's bio here, but we have a wonderful one here for Dr. Miller. Dr. Julie Miller earned her Doctor of Medicine from University of Alabama. Oh, we have any Tide fans in here? Then completed her radiology residency at Emory University Hospital System in Atlanta, a great hospital. She began her practice as an officer in the United States Air Force at Eglin Air Force Base. Dr. Miller was deployed with the 96th Medical Group to the Middle East as part of Operation Iraqi Freedom. Extensive family history of breast cancer led her to breast imaging. Dr. Miller has been doing vacation coverage intermittently for Bay Radiology since 2002, whatever that said. While in practice in Orlando, she moved to Panama City to join the team full-time in 2020. She's been a dedicated breast imager for more than 20 years. Come on up, ladies, doctors. They're both wearing their beautiful pink. Dr. Davis promises I can borrow that at some point. That jacket, it is adorable.
So I'm Dr. Miller, and it's my partner, Dr. Weintritt-Davis, and somehow her bio got lost in the connections, so I was going to let her do her own bio, and then we kind of were wanting to be the people that kind of filled in the gaps. Michelle, you did an amazing job. I mean, tons of information, extremely helpful. We didn't want to duplicate anything that anyone else was doing, so she's laid the groundwork for us. So once Lindsey's told you about her education and background, we were just going to share kind of what we do as breast imagers. You know, obviously you know why it's important from Michelle's lecture, and just kind of show you some of the newest technologies and things that we can, you know, kind of show you and let you see how we do what we do. So go ahead.
Like she said, I'm Dr. Lindsey Weintritt-Davis. I actually was born and raised in Panama City, Florida, and moved away for my education and then have been back practicing at Bay Radiology since 2013. I did most of my education and training at the University of Florida, undergrad, med school, radiology residency, so I'm a Gator for life. That's right. And then I did a year of breast imaging specialization, a fellowship in Washington, D.C. At George Washington University. And then I've been back here practicing at home ever since, and it's been lovely. So we are excited to talk to you a little bit, like she said, about sort of the diagnosis piece of breast cancer, the imaging piece, like Jessica mentioned. Mammography is what we specialize in, but we've got some other new technologies that we'll share to sort of talk about how we get patients to treatment.
And then we kind of also did something kind of fun. We kind of joke. We work back and forth with each other since Michael took out half of our building. But we get asked the same questions all day, every day, year after year. And it just seems to be things that, I don't know, we call them myths, but they kind of go through the community. And so people go, is this really true? Does this really happen? So if we have any time left over, we tried to keep our talk kind of brief. And we thought we would hit on some of those. And if there's gaps, at the end or anything, and people have ones in particular they want us to address, we will. But just kind of as a fun way to kind of hit those topics that maybe we won't cover in our actual lecture. So I guess I'll let Lindsey, she's going to take the first part of this and then go from there.
Okay. So we heard lots of these statistics with the first talk, so I won't belabor the point, but we know that breast cancer is incredibly common, and in fact now the most common cancer that we deal with, which is why we spend all year talking about breast cancer, but October we focus on breast cancer to really bring awareness because it is so common. 1 in 8 women will be diagnosed, and if you look around the room, that's more than a handful of the women in this room, just by the statistics. And like Michelle said, more and more patients are being diagnosed younger and younger and younger, which is why we really want to focus on the recommendations of when to begin screening, how often to be screened, so that patients are aware and can be proactive. So when you call to schedule your mammogram, they will often ask, or most likely ask, do you need a screening mammogram or a diagnostic mammogram? And most patients are like, I don't know, whatever my doctor wants me to have. So we thought we'd talk about the differences so that you can make sure that you're scheduled for the right test and you get the right care when you're there. So a screening mammogram, really a screening test of any type, and we screen for lots of different diseases, is in a scenario where you have no symptoms. You don't have any cause for concern, but we know that if we check, we might find something that you weren't expecting, and that's the case with the screening mammogram. So that's for patients who, no issues, no concerns, it's just time for their yearly check. We recommend that patients start having their mammograms at age 40, at least at age 40, and then have a mammogram every year after that. So in certain circumstances, like a family history, or if you have a known genetic risk factor, that may be earlier. And so, it's important to talk to your doctor about whether those things apply and really get a detailed family history. But for sure, starting at age 40. Now, because of the Affordable Care Act, it should be completely covered by insurance. There should be no out-of-pocket cost. We're finding most carriers even cover tomosynthesis, which we'll talk about a little bit in more detail, the 3D mammogram, but we can always check that ahead of time, just so there aren't any surprises. And then for a screening mammogram, you come, it usually is pretty quick in and out. You just come, get all checked in, get undressed, go over your history with the technologist. They do your images. Typically a screening mammogram is just 4 images, 2 on each side. Every now and then they may have to add some additional pictures just to make sure everything's covered. And then you're on your way, and it's read by the radiologist, and then that report is sent to your doctor, and then even uploaded in our portal. You can usually see it later that day or the next day. And if everything's good, then you just come back next year, quick and easy.
And I'm sorry, I'm going to take this out because I'm a lot shorter than she is, so I can't quite get all the way up to that microphone. Okay, so the first part of that discussion was the screening mammogram. You're asymptomatic, you've come in, you've had your mammogram. Now you get this letter in the mail that says you need additional workup, please contact your doctor. So that's where I'm going to come in. I'm going to talk about diagnostic mammograms. So diagnostic mammograms fall into 2 categories. One is you had a screening, but there's something we need to deal with or we need to look at more. Or B, you have a symptom. So you've got a lump, You've got a change of your skin. Your nipple is starting to invert. Or the one thing that kind of throws people is they're like, gosh, I woke up and I had this stain on my shirt. I don't really know how it got there, but it keeps happening. And that would be nipple discharge. And most people, when they think of nipple discharge, they think of breastfeeding. But it's a little bit different. This is sort of a discharge that's produced by a disease in the breast. Not always cancer, but generally a disease in the breast. So if anyone tells you, I feel something, there's something in my armpit, the breast feels heavy, or it's getting smaller, or the skin, anything that is not what it should be is the cue to let your provider know because you need a diagnostic mammogram. So the difference in these two exams is the screening mammogram. Lindsey and I sit down at various times during the day and have a lot of images to read. The diagnostic mammogram is a very intense sort of thing for us. We have an assistant that sits with us. We have all of our beautiful techs who are sitting over here who bring us images, tell us the story, tell us what's going on with the patient, why she's here. We look at the images. We say, is this good enough? Do I have what I need? Do I need something else? And at that point, I may look at the tech and say, I really need you to go back and do this specialized image or this image. They go do it. They bring it back to me. Then I'm like, okay, that's good. Now I need my ultrasound tech. I need an ultrasound of this, or I need whatever it is that I need. They go and get all those images. Then we put them all back together. So the patient may be presented to me on and off 3 or 4 times. So for patients, I tell them it's kind of a long visit, and it can be a little bit stressful, but we're sitting there kind of holding your hand, going through the process, and we're going to give you an answer before you leave. The answer is, everything's great, see you next year. We'll see you in 6 months. We need to refollow this or recheck it. Or, hey, we need to take a look and do a biopsy on something. So again, they always have the time to sit down with us face to face. They sit within a foot of us. We go through their images. We kind of, like she was telling you, and kind of get people prepared. Because, you know, the biggest thing about this whole breast cancer thing, it's all about how, I don't want to say it's all about how the journey starts, but it kind of is. I mean, we have a chance to set the tone with our patients about, you know, don't be fearful of this. We've made amazing advances. We just need to take care of it because women are warriors, and if they don't know, they worry. So the sooner I can give them an answer one way or the other, definitely sets the tone for a very positive experience through a very difficult journey. So the thing about diagnostic mammograms is those in general, insurance companies love to put those under deductibles, because they're not considered, quote, screening. They're a specialized study. So that's one of those things that kind of catches people off guard, because for years, people would say, oh, my doctor's made me a diagnostic mammogram for 20 years. I always get the results when I'm here. You know, we hear that a lot. And the reason that we convert people over to this is because otherwise now you have to pay for it. So it's better to go through the proper channels, because you may have a great mammogram and not need to come back till next year. No expense needed. The final thing is, like I said, we do everything we need at the time that you're there. The only thing we don't do while you're there that day is the biopsy, or if you need, say, an MRI or some other specialized exam, that would be an additional appointment. But that's kind of the gist for diagnostic versus screening. All right, I'll hand it back over to Lindsey.
So this, I'm actually going to go back a couple, since you happen to have that cute little cartoon in there, to talk about quickly what is a mammogram, and then we'll talk about tomosynthesis. So for those of you who have not had the pleasure, this is a cartoon of a lady having a mammogram. And the traditional 2-dimensional mammogram is a very simple test. It's not complicated. It's just an x-ray of the breast. Now, different than you might have an x-ray of your wrist or your foot or your chest, we do have to position the breast tissue, you know, because you can't, you know, you have an x-ray of your hand, you lay that flat out on the film. We can display all the anatomy really well. That's the purpose of that compression, which is the part of the mammogram that no one prefers, but it's the most important part, along with the expert positioning done by the technologist. All of that is designed to, just like you spread your fingers out on the film to get a beautiful x-ray of your hand, is to display all that tissue so that it's all included. Because if we don't pull all the tissue on and compress it so that it is nice and still and smoothed out nice and evenly, we don't get great images, and it's all for naught. So hug your technologist if they use a generous amount of compression. It makes it all worth it, and gets beautiful images so that we get a really accurate diagnosis. So you've probably heard about 3D mammography also referred to as tomo or tomosynthesis, all different names for the same test. And from a patient's perspective, it's really very similar to a mammogram. The compression and the positioning is exactly the same. The only difference is that the machine, instead of just taking that one image perpendicular to the breast, which ends up being a two-dimensional image of a three-dimensional structure, the tomosynthesis adds a series of very low-dose images taken in an arc across the breast, and then the computer has a program that puts all that into a beautiful stack of slices for us to scroll through. It appears similar to a CAT scan or a CT, where you literally can scroll through the breast. And I've got a few images that I think will illustrate why that matters to us, but it definitely has helped improve our accuracy at diagnosis. And to the patient, it is a tiny bit more radiation, but it ends up saving you additional imaging down the road and gives us a better cancer detection rate. So from a safety perspective, we think it's worth it. So here's a case. Oh, good, the video is playing. So on these images, the one on the left is a traditional two-dimensional mammogram. This one that's you can sort of see as playing in a video is a tomosynthesis, and that's how we read them. We just scroll with the wheel and it slides up and down. So if you look, you may see a few things sort of pop into view, and that's because that's just on an individual slice. I'll show, we've got a few freeze frames so you don't get dizzy trying to follow the video. Here, come over here a little bit so I'm not breaking my neck. So if you see that yellow circle, you see that area is kind of jagged. That would be, I don't know if there's a pointer here. Oh, look at that. Okay. So it would be in that area of the mammogram. I mean, do you see that? That jagged area? I mean, I look at a lot of these. I don't see it well there. It would be easy to pass up. But here, it jumps out at you. That's something we call speculation or architectural distortion. Sort of looks like somebody pinched it in the middle and it's pulling. That's generally a worrisome sign on a mammogram. Benign things don't do that. They grow nice and slow and nice and smooth, so they don't tug at the tissue like that. Here, that smaller circle, there's a nice, smooth little round mass. So there's two findings on that image. You can kind of see that little mass here on the two-dimensional mammogram, but it's much better seen there. And then she actually had a couple of additional findings as you scrolled through the tomosynthesis. There's a little cluster of masses, and then there's a more subtle but circumscribed mass right behind the nipple. So 4 findings that are not well seen, certainly much better seen on the tomosynthesis. So we found, it adds so much to our ability to accurately diagnose patients. Number one, it's more sensitive, meaning it finds more things. Hopefully finds more cancers. It does find more benign findings, but as we've learned, we can sort of strategize and triage things and not call back every single little benign mass that we see. We just look for the more suspicious findings. Another benefit is because we're able to look at that tissue slice by slice by slice, in the past, you might see an area that just looked a little bit different than last year. And you think, like, is that something? Is it not? Should I call it back? And on the tomosynthesis, it really helps improve your confidence that, no, this is a real finding that needs to come back, and it often will save the patient an unnecessary callback or a false positive where it was just overlapping tissue. Because when we can sort of look at the individual slices, take the tissue off that's above it and the tissue off that's below it, we see that it's just normal. So it improves our sensitivity, finds more cancers, it improves our specificity, less false positives and unnecessary callbacks. It also helps save patients some of the additional mammogram images when they come back. A lot of times we can just go straight to ultrasound because I can look where in space and say, she's got a finding at 3 o'clock, 6 o'clock, 9 o'clock. I can describe them. It gives a lot of direction to the sonographer. So it also improves the diagnosis when they come back for their diagnostic imaging. There's a couple more just examples to illustrate the point that the finding on the two-dimensional image, pretty subtle. And then here, you see all that speculation. Another case. Hopefully I've made my point, but it's better.
Okay. All right. And if it's okay, I'm going to trade sides because I think I'm going to have to do the same thing she did. If I'm blocking you, anybody just stop me. So one of the things that Lindsey was hitting on, which is sort of what's going to lead to this, is everything that we're looking for the most part, is white. It's a white finding, and I'll show you what I mean by that. So the mammogram here on this side is fatty replaced, and it gets gradually more dense. The gray is fat in the breast. So the more fat you have, the more things that are white are going to jump out. You can see as you get down here to where everything's white, it's very hard for us to pick out things that are really tiny and catch them super early. So this conversation, I'm sure you've seen it in the media maybe, but it's called Are You Dense? It's not asking how smart you are. It's saying to women, know what your breast density is. And because the gist of the story is that it's hard to hide a cancer right here. It's very easy to hide a cancer right there. So it just lets women know that are in these two categories right here that mammogram alone, 2D mammogram, is not enough for you. Yes, a 2D, 3D mammogram is much better and is great, but you still have a little bit further to go, which is where breast ultrasound comes in. And like I said, a lot of states started enacting in the early, 2008, some states passed mandates that you had to tell patients their breast density in their reports. And it hasn't become a mandate here in Florida, but as a practice, good standard of care practice for breast radiologists around the country, we put it in there. So if you ever look at your report, the very first thing you'll see is you are heterogeneously dense or dense. When you see that word dense in your report, you've got to know that you've got to take one extra step, that mammogram alone is not good enough. And anyone that tells you it is, you need something else. Okay, so again, everything we're looking for is white. So you can see where you get down to the third and fourth categories, how hard it can be. And that's where the tomo that she was showing you is critical. Because for us, it's like flipping through the pages in a book. And I can tease out little things. I can find things that you would never see on that mammogram ever. But you see them on tomo clear as day. So when you hear people say, my mammogram never found my cancer, part of the question is what type of mammogram, what's your density, all those factors kind of go into that. Okay, so again, this is a fatty breast right here. Sorry to be blocking, guys. Fatty breast, and there's a little cancer, a little irregular mass sitting right there labeled cancer. Same thing is actually present in the other side, but you'll never be able to see it. So that's kind of just showing you the example. So how prevalent is dense breast? Many, many women premenopausal, like 2/3, are dense. As we age, the breast naturally, without hormone supplementation, should gradually become less dense, which is good because, as Michelle told you, your cancer risk is going up. You want your breast density to be going down. So just keep that kind of in the back of your mind. So for the longest time, this was our option for breast ultrasound. Everybody that's ever had an ultrasound, it's a handheld transducer. It's fairly small, but it takes time. If you've ever had an ultrasound, they really have to be looking. The technologists have to be very knowledgeable. They have to cover all the tissue. But a lot of women never got breast ultrasound, even with dense breast parenchyma, because this could take an hour and a half, depending on what you find in the breast. And it was time-consuming for women. It was hard on everybody. And again, it's a great idea. It's just, are there enough technologists for every dense breast woman in America to have an ultrasound? And the answer is probably not. So they kind of solved this problem by creating something called automated breast ultrasound. So the difference is, let me see if I can make this go. There it is. Okay, so see how big this paddle is? It's a nice large square, and probably 3 positions would cover the entire breast in probably 90% of women. And each image just takes a few minutes. So by the end of a 15 or 20 minute acquisition, you've scanned the entirety of both breasts. The good news is it doesn't leave it to the technologist. They don't have to figure out what it is. They can just literally acquire the image, and then we get to do the rest. And I'm going to show you kind of how it presents when we see it. Now, I'm just going to tell you, when I put this screen up, it's going to automatically go into a loop, so just try to ignore it. But I'm just going to tell you, you'll notice that there's a set of images, and I'll show that to you, where you're looking straight at the breast. And you can move forward and backward through the breast this way. And then there's other ones where you can move this way. And so you have the ability, kind of like anything, it's almost like a game, like a video game. You can maneuver yourself around wherever you want to be. And it also, everywhere I am in space, it says to me where I am on the clock face and how far I am from the nipple. So I'm just going to kind of show you and let it run for a second so you can kind of see. Ooh, maybe it's not going to run. That's actually better. Wait, hold on, don't hit it yet. Don't hit it, because I don't want it to run quite yet. So these images right here, these two images that are right here on the side, you can see on that picture, see that little yellow dot that's in the center? That's the nipple. And you can actually scroll, I can actually take it from the nipple and go all the way back to her ribs and all the way back out to the nipple. So I can do whatever I want to do in this plane. And that little sort of crosshairs up there, that's where my mouse is focused. It will tell me on these images the corresponding match. So I get to look at a piece of tissue from any direction all at the same time, which is fascinating because once you've done this, and you can see, it'll see like 10 centimeters from the nipple, 1030 position, 3 centimeters from the nipple. It'll tell you where you are. The beauty of this is once you've had a few negatives, it's almost like I have an encyclopedia of your breast on ultrasound. So I can just sort of move my way through. Next year I can go, wait, let's go back last year and look through the tissue because I have all of your breast, not just the pictures that were captured by a technologist, if that makes sense. So you kind of get this volume of information on the breast, which is very, very handy. But the last caveat to this is, remember, when you had this, right here, all of the energy on the ultrasound beam, I know you're loving this, the whole science thing in you, but you have a small transducer, and all the energy is focused in one spot. You get great detail. You take the energy and you now spread it out over a larger space. The detail's not as good. So on occasion, we'll do one of these, we'll see something, and at that point, the patient does have to come back for us to use the handheld to really get good detail. Not always, but sometimes. So I always tell people, just because you had an automated breast ultrasound does not mean you will never come in for a handheld, because there's a chance that you will. Okay, see if it'll go, Lindsay. Now, this was my husband and I in my office the other day, just trying to quickly capture this slide, so I'm sorry about the background noise. But do you see how as you're moving the cursor, it's moving you through the breasts? And like I said, I have the ability to twist it, go at it a different angle. I can pick whatever I want to do and just sort of make my way through there. But it's a really great way to bring this technology to the average patient, because we probably see, I'd say 50% of our patients, probably 75 people a day are dense. These poor technologists would never go home and never sleep if we tried to do this on everybody. But this is a beautiful thing because that way we can get a lot of patients screened who have never had it before. So that's kind of the plus on that. And really that's about it as far as our technologies go. I don't know how we're doing for time. You good? Because I was going to say, if any point anybody wants to come up and ask us questions later, like I said, we have myths and things we can tackle later, kind of frequently asked questions. But if we don't get a chance to do any of that tonight, feel free to hit either one of us up, and we'll answer as best we can. Because that's it. Okay.
All about saving lives. Wow, that's amazing. We heard Jessica talk about the importance of self-exam. We have Judy Crowder with us here tonight. She goes a little deeper, so to speak, into how to do the breast self-exam and why it's so important. Where did Judy run off to? Oh, there she is. And she's also going to talk about the beads of hope. And that's an interesting topic there.
Thank you so much. I'm actually Judy Crowley, but you can call me anything you want to. It makes no difference.
That's okay.
My relationship with breast cancer goes way back. When I was a little girl, I was at my grandmother's house, and she was a nurse. She was getting ready for work. She worked a late shift, and I'd never seen her without her shirt on. She was getting ready for work, and I walked in her room after my bath, and I was about 8 years old. And I realized that she was very flat, didn't have nipples. It shocked me. And I said, Grandma, you're just like me. I was 8 years old. And she explained to me that she had had breast cancer at 50 years old and had undergone the treatment that was available at the time, which was cobalt radiation. She had many, many burns. She had no... I guess her muscles under one arm were gone. She had sort of a big hollow spot Didn't have use much of her right arm, but she was still a nurse, could still do everything with her left hand. But that was when I first learned about breast cancer. So I just sort of filed that in the back of my head. Didn't think about it again, except what I was thinking, I think, was that breast cancer is not all that scary, because here's my old grandmother who's doing everything she wants to do, and she survived breast cancer, so I really didn't give it a whole lot of thought. So many years later, I'm the executive director at a family resource center in Enterprise, Alabama, sitting at my desk minding my own business, and a lady walks in who several people in this room know. Her name is Miss Lucille Latham Willett, and I have to describe her to you because I want you to get a little picture of her. Have you ever heard that phrase, probably your grandma used, says, dynamite comes in small packages? Well, that was Miss Lucille. Miss Lucille was a very small woman. She came in my office, not the normal family services client. She had on sort of the Jackie Kennedy suit, except it was hot pink. She had this impossibly teased up hair in an unnatural shade of red, perfect makeup, and gold high heels. And I figured she was well over 70. And she said, we need to talk. I said, okay, have a seat. She said, do you know too many women are dying with breast cancer? I said, yeah, I know that. She said, you have to do something about that. And I said, well, I'm not really sure what I'm going to do about it. She said, well, the state has this program where women who don't have insurance can get a mammogram. Now, I want you to do something about this, because women aren't using that program. They're not coming and getting their mammograms, and too many women are dying from it. She said, I'm going to have some surgery day after tomorrow. I'll be in the hospital about 3 days. You need to think about this and let me know what you're going to do about it. I'll be back in the morning and you can give me your answer. So I'm thinking, I'm really in trouble here. I don't know about this lady. But I started doing a little research, and I realized that women, black women in particular, were dying at a terrible rate from breast cancer, that white women had better early detection behaviors, of course, because more white women were insured at the time. So I gave it some thought, started looking into what we could do, and found a little grant, wrote a little grant, and by the time Miss Lucille came out of the hospital, I invited her to be our breast cancer educator, because who could say no to Miss Lucille, right, Dr. Stokes? Just couldn't say no to her. So the reason I'm telling you this is because in the 12 years that she assisted us, she was in her 80s by the time she retired, she saw about 10,000 women every year to tell them about the importance of early detection. She wore me out, frankly. Totally wore me out. So Miss Lucille had this real Southern accent. She was very, very sassy. You can imagine her already with the red hair. And she would come into the office. There were 8 women in the office at the Family Resource Center. And she would say, have you done your self-exam this month? I mean, in that tone. And I felt like she could look right through you and know if you were lying about it. So, yes, ma'am. Yes, ma'am, I did. Okay, no, it's not due until next week. So you always had to explain why you had not done that if you had not. Have you had your mammogram this year? It was that way. Everybody she met, she made sure that if you didn't have a way to do that, she would find a way for you to do that. She went to jails. She went to slums. She went to factories. She went every place where she could find women who would listen to her. And I really believe she saved hundreds of lives. The reason I'm telling you that is the information that you're getting here tonight is good for every citizen to use. I'm not clinical. I'm not a clinical person. I'm an educator. I have information from tonight that I can use with other women to tell them how important it is to get your breast exams, to advocate for yourself, and do your monthly self-exams. Lucille, an ordinary citizen who had been a hairdresser and still kept that hair about this high, saw hundreds of thousands of people. So anybody in this room can be that person. even if it's just with the people around you, just to be able to tell folks you work with, remind them, you got to get that Lucille attitude and say, have you done your breast exam this month? But get that Lucille attitude and be sure to tell people around you. Now, we started doing a breast cancer program in 92, I believe it was. No, it wasn't 92. It's 2000 that we started doing a breast cancer program. And it really consumed a lot of our time. So one year I was turning 50 that year. I had gotten my mammogram right on time in April. And it was a clean mammogram, although I had family history, never had a problem, never had anything. And our breast cancer symposium was coming up in October. Dr. Stokes was on the program that time. And I had not really felt a lump, but I had pain in my breast. But that means nothing because breast cancer is not supposed to hurt. But it felt like somebody was stabbing me. But I thought, I'm under a lot of stress. My mother was terminally ill. I had this breast cancer forum coming up. We were seeing hundreds of people every day in our business. And I didn't, unlike the first young lady who had this urgency about getting it seen about, I didn't have that urgency. I thought, well, this can wait a little while. So my self-exam rolled around at the end of October, and I found a pretty big lump. I thought, that's absolutely nothing. I'll see about it in a couple of weeks. So a couple of weeks later, I called my dear friend in Enterprise who's a surgeon, and I told him, he said, well, go see your OBGYN, and let's see what's going on. So I went to see him, and he said, raise your arms. He said, I see that lump already. I can see that lump without palpating it. Went downstairs for a mammogram, and the radiologist said, show me where you think this is, and I showed him, and I said, and it's about 25 millimeters. He said, you can't know that. And I said, I can know that, and I'll show you why in just a minute. It was the day after my birthday, on my 50th birthday, when I had my lumpectomy. The tumor was typed and graded. It's not a good thing to have a high grade when you have a tumor. You want good grades in school. You don't want good grades when you've got a tumor. It turned out to be triple negative, which is, I'm just going to tell you, it's no fun. Triple negative is no fun. It always requires treatment. The path through treatment is not all that clear, but I will tell you they hit it with everything they have. The survival rate is not that great with triple negative, but to me this is still kind of an annoyance, right? Just needed to get through it. Had great care. Dr. Steve Stokes, Dr. Sam Sawyer, Dr. McAllister in Enterprise in Coffee County and Dothan. Tremendous treatment. Absolutely tremendous treatment. And here I am, 15 years later, turning 65 this year. And here I am. So I'm happy to be here. But let me tell you about those self-exams. The American Cancer Society and BreastCancer.org do not recommend self-exam. The only thing I can find, any kind of writing I can find online, is that self-exams tend to give women a lot of anxiety and cause them to go to the doctor more. I'm going to tell you something. I have way more anxiety about dying with triple negative than I do about feeling of my breasts every month. That gives me no anxiety whatsoever. In fact, I just have this little party when I finish those. Maybe dance around the room a little bit, do a little hoochie-coo, because here you are. Got on nothing up here. You might as well do the hoochie-coo in private, right? So we're going to talk about breast self-exams. You've got a little handout here. We're not going to go through all of the steps, but you've got this handout. It's a pretty simple thing to do. And I'm not clinical, so some of you folks who are can correct me if I'm wrong. If you're still having a menstrual period, the best time to do your self-exam is about 10 days after the first day of your period. That's when your breasts are the least sensitive, from what I've been told. If you don't have a menstrual period, then just pick any day you want to and stick with it. I stick with my birthday date which is the 23rd of November. So the 23rd of every month is the day that I do my self-exam every month. Something that mammography and tomography and ultrasound, all those things are incredible tools. What they don't tell you is there's a lot of breast tissue there that doesn't fit in your bra. Breast tissue goes all the way up to your collarbone, down under your armpit, and under your bra line. Am I correct? For all you clinical folks, tell me yes or no. So there are places you need to be checking that aren't compressed in that little machine. So check anywhere below your collarbone, down under your arm, and down to your bra line. All of that is breast tissue and is subject to breast cancer. The first time somebody told me that, I wanted to run out of the room and go to the bathroom and check because I didn't know that. So if you want to run out of the room, help yourself. But when you do a breast self-exam, you have to press pretty hard, but don't do it like this. Do it with this 3 fingers, just like so. Your instructions will show you that a good thing to do is to make a circular pattern, working toward the middle. Take your time. Walk your fingers around. Don't lift them up, just walk them around. Doesn't take long. The instructions are simple. Press pretty hard. If you find something, watch it a few days. If you have fibrocystic breasts, that's going to be hard to figure out. But once you've done this a few times, you get to know the lay of the land here. You get to know your body. If you find something you want to check later, draw yourself 2 circles on a piece of paper. You can make those as big or as small as you like because this is just for you. And you make yourself a mark. This is where I found this. I'm going to look at it later. I'm going to feel it later. I'm going to call my doc and tell him about it. So when I did that breast self-exam, after I'd had a clean mammogram in April, found that 25 millimeter tumor that was triple negative, I realized that that tool was the most important tool in my toolbox because triple negative, like I said, is no fun. And if I had waited 7 more months till my mammogram was due again, I might not be standing here today. Or I might have had to have more chemotherapy, or I might have had to have more difficult treatment. So years ago, we came up with this little tool that's just a reminder. It's not awfully scientific, but if you'll pull these out of your bag, we're going to talk about these just a little bit. It's called the Beads of Hope. I had a first cousin who was a surgical oncologist, and we talked about what can we do to remind women to do a breast exam. And I've seen the things you hang in your shower and the things that go in your calendar, but I wanted something you could hold in your hand. So if you'll look at these beads, is someone in here in the room, people who made these beads? Thank you. This is a work of art. Thank you so much. My children are grown now, but I think they can make these in their sleep now because when they were growing up, this is what they did. They made lots and lots of these. There's a great big bead here on the end. I want you to look at that one and feel of that. Roll that around in your fingers. This one is about 20 millimeters, right? This is a little smaller than the tumor that I had. This is a 20 millimeter bead. This is unscientific, but it's a reminder. This is about the size of tumor that's found by people who don't do self-exams and don't have regular mammograms. The next bead here is about 16 millimeters. See, I'm good at this. This is about the size of a breast tumor that's found when you have an occasional breast exam, an occasional mammogram. This next one is 8. Okay, good guess. 8 millimeters. You can find a tumor this size, a lump this size, with a self-exam. So That's a really good thing to know. In fact, you could find a lump smaller than that with a good self-exam. The bead that's long and skinny like this is to show you that not all breast cancers are round. So what you're looking for is changes in your breasts, changes. This next little bead, mine is black. It's the next to last one, and that's about 5 millimeters. I'm batting 1,000 here. It's about 5 millimeters. You can actually find a breast tumor or a breast lump with a self-exam that's about this size when you get really good at it. You see this tiny, tiny little bead that you can hardly see here that's about 4 millimeters or 3? A mammogram can find that. And now probably a mammogram can find something way smaller than that, except they wouldn't be able to thread it on this wire to show you. So the reason this is your reminder is I want you to look at this big bead on the end that's 20 and this little bead down here that's 3 or 4, and I want you to tell me which one you'd rather have if you have breast cancer. We have a problem that's this size compared to a problem that's that tiny size. It's much harder to solve than this tiny little thing here. So early detection is the key. All of these things make a difference. Your mammogram, your self-exams, all of those things make a difference. Your clinical exam, many docs are still giving clinical exams in your regular doctor's appointments. All of those things are important. They're in your arsenal. That's how you protect yourself. And I want you to keep these beautiful things. Thank you so much for making these. As a reminder, and I thank you all for having me today. This has been a great conference.
I want to know how many of you in here are breast cancer survivors? How many cancer survivors? Including breast cancer. All cancer survivors. Well, hopefully this information that you hear tonight will help you to save other lives as well. I know we have at least one male breast cancer survivor here tonight. He's sitting over here, Mr. John Hewitt. He was one of those less than 1% of men who have been diagnosed with breast cancer, and just last Thursday, he rang the bell. His doctor back there, Dr. Stokes, he loves him, and Dr. Haberman. Let's see, back here. They really are. He's bragged about you guys a lot. And we are going to hear from one of those doctors right now, Dr. Christopher Haberman. Yes. I'm at that age. Dr. Haberman is a board-certified medical oncologist at Florida Cancer Affiliates. He, I think that says, graduated with honors from Mercer University School of Medicine in 2002. That's close to my hometown. Having more than 19 years of experience, Dr. Haberman is committed to providing patients with the specialized care they need, along with the tools, resources, and personal support. Dr. Haberman can be reached at Florida Cancer Affiliates, and the number I can give you later if you would like it. Thank you, Dr. Haberman. You can have this.
Oh, great. Thank you. I appreciate that as a very good introduction. That must be y'all's talk. Sorry. Okay. Yeah, I'm very privileged to be here, in such a esteemed company, and I'm batting cleanup for you guys, so just bear with me. Y'all asked me to talk about something, the treatments and things like that with oncology in a short period of time when literally we go to conferences. It could take us weeks to go through any of this. So I'm going to talk briefly about the treatments, kind of the words you'll see on TV and what's being advertised so that you can kind of understand a little bit what it means to come see us, and then briefly about survivorship at the end. So I don't want to rehash what we've already been through, but you know, you've been told you have cancer, so now what? You get referred to all these different doctors, you have all these different specialists and a team of people, as you can see. So it does make up a team, and certainly here locally we all communicate together, which is important. So the doctors call each other, we all have everybody's cell phone numbers, which is all very important. In my office, I have radiation oncology. I also have Dr. Weber and other partners, so if I have questions, it's always nice to have a colleague to go over things with. But so part of the team will be the surgeons, obviously. You'll have the pathologists that are behind the scenes. You don't always meet them. With Bay Radiology, you have the radiologists that you do actually meet, but most of the radiologists you don't meet. They're reading CT scans, et cetera. Then you get referred to someone like me, a medical oncologist, a hematologist. Then you have the radiation oncologist, which is Dr. Stokes and Dr. Finkelstein in my office. But part of the team is also nurse practitioners, PAs, all the ancillary staff, the front office. I mean, all these people are very important in your care from when you hit the front door into my office and get escorted back to see us. The thing for me is I always tell patients, bring an extra set of eyes and ears. I think it's important. You know, you mentioned the word cancer. A lot of times everything just shuts off. And it's always nice to have a family member to support you, have a friend there to support you. Many times they'll hear something that you may not hear. So it's always nice to have that extra set of ears. The other thing I highly recommend is if you're in an office, maybe you ought to take a tour of the office, see exactly, you know, where the treatment room is, if you need treatment and things like that. I think that's all very important for patients and kind of ease some of the anxiety. I think that's also important. So what do I do, or what do medical oncologists do? I think a lot of us know we give chemotherapy, you know, but really what is our job in our office, and what do we do for cancer patients and survivors? So our job is to offer preventative strategies to reduce the risk of cancer coming back. So, you know, I get asked this all the time, you know, why do you recommend additional treatment? You know, you see it in my second bullet point, why do I need anything? The surgeon told me I got it all out. I mean, it's out. You know, what do I need chemotherapy, radiation for? So all of our recommendations are based on, you know, the stage of the cancer, the type of cancer. You've heard about triple negative cancer. It tends to be more aggressive than some of the other breast cancers that we see or other tumors that we see. You know, so it's based on stage, it's based on what's called pathology, and it's all based on data. You know, a lot of stuff that we do or everything we recommend is based on patients that participate in clinical trials prior to FDA approval. So the other thing we'll talk about briefly is what about surveillance and follow-up after you've completed all your treatments, what next? And that's survivorship. So how do we decide what to do for a cancer survivor? Again, you'll hear us talk about guidelines. You know, sometimes we bring that up at appointments. Sometimes patients ask, they get on the internet because there's a wealth of information. There's also a wealth of misinformation. You got to keep that in mind. The internet's full of maybe quarter truth and three-quarter non-truth and myth and everything else. And a lot of the stuff that you read on the internet, maybe 20-year-old, 10-year-old data that we don't even use anymore. So you have to be very careful what you read. And I always encourage patients to be careful what you read. Avoid blogs where it's patients' individual opinions about treatment. I think get started, come meet us, then the doors are wide open. But you got to come down and meet us and go over things, and then you can be on the blog and preaching the truth out there. So what do guidelines mean? Exactly what are they? It's the standardization of oncology care. So if you're in Nome, Alaska, Panama City, Florida, MD Anderson, it doesn't matter where you are. If the doctors are following guidelines, you can get your treatment locally. This is the thing we run into day in, day out, is you can get excellent cancer care here in Panama City. We have excellent radiologists, pathologists, radiation, the list goes on and on. You do not have to travel outside to get any different therapy from us than you would anywhere else. And that's the biggest misnomer that we have to get out there to the public, because I run into this all the time. I'm new to the community. It's frustrating to me. It's frustrating to our partners. You know, we meet somebody and they instantly say, oh, I need to go here. And it's like, well, you don't necessarily have to. We have it all here, but certainly that's your decision. So all of our treatment recommendations, as I mentioned, are based on proof. It's not subjective. It's absolutely, you know, if it fits within the box, we follow the guidelines and we treat you as they would anywhere else. One thing I do tell patients that's important is academic centers, MD Anderson, Mayo Clinic, wherever, you know, what they have to offer that we don't have to offer are what are called clinical trials. So these are something some patients are motivated to do. This may give you access to the latest and greatest treatment that's not currently FDA approved. The biggest misnomer about trials is I'm going to be a guinea pig. They're not going to give me placebo, which means a sugar pill. Generally speaking, most clinical trials that oncology patients participate in it'd be unusual for it to be a placebo trial where you did no treatment at all. It would be compared against standard of care treatment, maybe with a placebo on top. So just keep that in mind and stay open-minded to clinical trials. That's something we certainly are very interested in, and at some point in the future, hopefully we have accessibility to clinical trials here locally that we don't currently have. So what are the treatment options for cancer patients when they come and see a medical oncologist? Everybody's heard of chemotherapy. Most chemotherapy is IV. We do have pill form of chemotherapy. We discuss the treatment options at the appointment, go over chemotherapy education or whatever treatment we're offering you. We tend to go over it and explain it to you, so hopefully you're well educated and know what you're getting into. The latest and greatest and most exciting stuff for us, and it's really changed my short career, is you see about immunotherapies. This is on TV all the time. This has been a game changer for us. Kind of a side note is targeted therapies. They're very similar. I mean, immunotherapies are targeted therapies, but there's other treatments out there that are targeted that aren't necessarily immunotherapies. What that does is it takes advantage of maybe a mutation that we find. I think there's a lot on the internet about, are we checking for mutations? I get asked this every day, and of course we are. That's standard of care, and that's something we do here for everybody. So what exactly is chemotherapy? I mentioned it can be IV or oral. It is a systemic therapy. So what I mean by that is it goes in and it goes everywhere. If you have cancer in your big toe, it's going to circulate down there, assuming you have good circulation, and it should hopefully take care of things for you. It does have a bad reputation of making people sick. I think a lot of that is a lot of information from way back in the good old days when everybody did get sick. It wasn't uncommon for oncologists in the early 90s and late 80s. They'd have 30 or 40 patients in the hospital, and they all were suffering from chemotherapy-induced nausea and vomiting or low blood counts. So again, what I mean by that is the pre-medications and the technology helping prevent nausea and all these other side effects is much better today than it once was. Plus, the drugs are cleaner, they're less toxic, they're more specific. But chemotherapy does have its list of side effects. It can affect multiple organ systems and cause all kinds of different potential side effects. So what is immunotherapy? This is a type of targeted therapy. Immunotherapy is usually given intravenously. Basically what it does is it augments your own immune system to hopefully kill cancer cells. In general, it can be less toxic, but don't be lulled into this sense of safety or false sense of security that doesn't have side effects. It certainly does have side effects. They can be dangerous. People have passed away from complications of immunotherapy. The other advantage of immunotherapy, many of them, certainly not all of them, we have exceptions to all these rules, it's a much quicker infusion. It's usually not nearly as long. Many of our immunotherapy infusions can be less than an hour, where some of the chemo infusions in combination can be 3 or 4 hours, if not longer. So kind of a side note, targeted therapies, what exactly do I mean by targeted therapy? Kind of backing up a little bit. One option, or one example would be an antibody. So an antibody directed to what's called an antigen. So we talk about breast cancer being HER2 positive. That's just seen on the surface of the breast cancer cell. We have an antibody called trastuzumab or Herceptin. That's been a game changer for us. It took a traditionally bad-acting breast cancer that was HER2 positive, extremely aggressive, and it has been a true game changer for us and changed the survivability of this difficult breast cancer. Other examples of targeted therapies in breast cancer would be something relatively new. It's called PIK3CA. There's a medication for this called Piqray. But what I'm getting at is there's mutations that we all test for, that we look for, and there's maybe a specific therapy that has an actionable mutation that we can take advantage of that with one of these newer medications. So how do we decide targeted therapy? I mean, how do we come up with all this? So what we do is we look for these mutations, and these are just examples. These are commercial labs. One's called Foundation One. There's one called Guardant 360. The list goes on, and basically what it is it's molecular testing of the tumor. So when patients come in and ask me about this, or I tell them I'm doing molecular testing, they think it's an additional test they have to do. You know, it's on pre-existing tissue. Once the tumor's been removed, It's saved in a wax block many times, and that's stored away. We can add these later down the line. The other thing you'll hear is something called a liquid biopsy. This is a misnomer of sorts. It is actually just a blood test, so it's not anything other than a blood test. What it's looking for is something called circulating cell-free DNA. So when cancer cells are present, they release DNA into the bloodstream. They have tests that can capture this and look for mutations, and that can help me decide medications to use to take advantage of this. I mentioned about tissue biopsying. Certainly you do bone marrow biopsies for hematologic disorders, and sometimes we'll do them for solid tumors. Briefly, just change gears here. What is survivorship and how is this important for patients? From my perspective, survivorship is defined by the American Cancer Society. It uses the term cancer survivor to refer to anyone who has ever been diagnosed with cancer, no matter where they are in the course of their disease. So from my standpoint, the cancer journey begins from diagnosis to remission. So it's not this point along the line, it's the entire trip and the entire journey. The other thing that's important to educate patients with survivorship is understanding what to look for with recurrences. You know, self-breast exams is an example. Obviously, bring things to your doctor's attention if you have symptoms and things such as that. So do the best to educate yourself on recognizing the signs and symptoms of recurrences. You know, that's what we're here for too as doctors. You ask us questions, we're going to answer them if we can. If somebody asks me a question, I don't know the answer, I'll be very honest and say I'm not sure and try and research it for them, or they can research it for themselves. Also part of survivorship is follow-up care. Again, this is all based on guidelines. You know, how often do we do imaging? How often do they come in our office? Monitor for recovery. We also monitor for long-term side effects from chemotherapy. Some of our chemotherapies have toxicities up front, but then many of them will have a late toxicity. Some of it's cardiac, and there's other things that can show up. Part of survivorship is physical and emotional support. That's something we all could work on here locally, but that's very important for survivorship. And then obviously, the last but not least is, you know, screening exams, follow-up, imaging, mammograms, CAT scans, whatever may be most appropriate. So, but that's it for me. Since everybody's talking football, I can't go without mine. So again, thank you. I appreciate y'all inviting me to this. This was very special, and hopefully every year we do this. Thank you.
Oh, you gotta love Uga. He's a cutie. We've heard from several of our experts tonight on the treatments available here and how they are just as good as anywhere else. And I heard that from John and Lynette last week when I was talking with them, had all of his treatments done here, and he is more than pleased with how it turned out, as we all are. And we are going to talk with Becky Dunaway. Make sure I get my glasses on. Who's a local nurse here, RN. Oh, there she comes. About some of our local resources that are available to everyone who is going through this journey. Do you want it off or on?
I'll just let it stay there. I'll just see if I can talk louder. I'm not good at this. Okay. My name is Becky Dunaway, and I've been with the Breast and Cervical Cancer Program for about 25 years now. The Breast and Cervical Cancer Program started with the CDC program, and they just had their 30th anniversary statewide, the United States wide, including Puerto Rico and everything. And they sponsor a bunch of different people in all the states to be able to allow women who don't have insurance and a way to pay for getting their screenings and stuff. Now, Florida decided when we set ours up, and ours started, in fact, Jackson County, we used to call us the Jackson 5, but then later I have now 9 counties, so there's a reason for that. But what we ended up with was we said that women who are 50 to 64-year-old fall through the cracks sometime, because the women who are 50, they probably not got children that are young enough to still get Medicaid. So they don't get us their screenings when they should. So then we said, well, we're going to be 50 to 64-year-old, have no insurance, no Medicare or Medicaid. And then we had to come up with something that we could do as far as the income thing. So we went with 200% of poverty. Now that covers a lot of women in the state of Florida. And so that's what we've started out with, and we had numbers that we actually exceeded for a while there. But now we have a lot of other people that are helping with screening and stuff. So now we've included women who are 50 to 64-year-old, and then we have women who have family who have the BRCA gene that we will actually start screening on whenever their doctor points them out and says, hey, I'd like a screening mammogram on this lady every year. And then we have also this year included women who have a first-degree relative. Now, that's hard for a lot of people to say, well, my great-grandmother had it or my aunt had it. But first degree means that we have mother, father, brother, or sister that would be in your first degree. And if any of those have breast cancer, then we will start screening them whenever they come to us. We've screened women as young as, I think the youngest I've had is 20. So that's giving some of those other women who still don't have insurance and they're still 200% of poverty have the ability to come through and get their screenings earlier. Now, like Alabama started out with 40 and to 64, and they had to go up to 45 because there were so many women that could come through their program at their 40th. So anyway, that's where we've had to draw some lines. And then in 2001 is when I got my 9 counties, and I cover Walton County, Bay County, Gulf and Franklin, and then I have Calhoun, Liberty, and then Holmes and Washington and Jackson. I've got them all. So we cover a lot of groups, a lot of women. And so in 2001, our governor's wife got breast cancer. And his wife's name was Mary Brogan. And so that is what our program is called. It's the Mary Brogan Act is what they called it. And the legislature, your tax dollars at work, actually pay for the women in our program to get their treatment through the Medicaid program. Now, it's pretty special because we don't have to be on a HMO or we don't have to have a special doctor. They get to go whatever doctor they need to get their treatment. So if the lady was found to have cancer in Jackson County, she could still go to Miami if she thinks that's a better place for her to go. They have to remain in Florida because Florida Medicaid only pays Florida providers. So that's one of the things and sometimes some of the drawbacks. But I've had women go to Jacksonville and decide they wanted to go over there, or I've had them go down to Shands and the others. Now, some of the places you have to make sure that you make sure they take Medicaid because some of them have decided not to because there's so many people that are on Medicaid. But ours is a special Medicaid. We actually get them approved with, the longest it's ever taken has been 2 weeks. I can sometimes get it within 3 or 4 days because we have a dedicated woman at Medicaid that only does our program. So that's what we do, and we're on every county in the state has the Florida Breast and Cervical Cancer Program. Now, if you live in another state, you would want to check and figure out what their breast cancer program does. So I do know Georgia's different, I know Alabama's different, but a lot of them have different things. Now that is basically what my talk was about, but what I do like to do is to have some questions. If anybody has anything they'd like to ask me about the program. I think I must have covered what was needed. All right. Well, I thank you for your time. We have a booth, we have a table over here that has some breast cancer facts and stuff like that. And if we have anybody that wants to sign up, we have a special bag that you can have for coming and signing up if you meet our criteria. And I appreciate your time. Thank you so much.
She's a dynamo, isn't she? All right. Who's ready for some door prizes? Take some of the chicken home, too. I haven't eaten yet. Get out of my way. All right. I keep referring to Lynette and John. I said, I keep referring to you two. Lynette is the one who's the brainchild behind tonight's symposium. She held many, 17 in Mariana? About 15 in Mariana. And their treatment brought them to Panama City. And so we have our first one. This year, hopefully, we'll have more. As we get more people involved, we'll have more attendance next year, too. When she did her last one in Mariana, it was about 400 people who were there in attendance. So we want to get this message out. It's being live streamed on Facebook. So, yes. Thank you, Lynette. Now, how are we giving away all of these wonderful prizes? How are we giving away this door prize? Which one is the door prize? Or do we have one door prize or more than one? We have two door prizes. Two door prizes. Do we actually get a door? Okay, I'm just asking. This is Lynette.
Hi. It's nice to be here tonight. This night reminds me of the attendance of what we had the first time we had ours in Mariana. And yes, we worked up to where I think we outgrew 4 different places that we had to keep moving to have somewhere large enough to do our symposium.
Here comes our Vanna White.
I had my first my breast cancer 17 years ago. I'm blessed. There's not much around the house that I want done that I don't do. And regretfully, I lost my husband that I was married to then when I found my cancer. But the Lord's blessed me with John. And we've been married almost 5 years now. He lost his wife and I lost my husband.
They met at IHOP.
On 23rd Street, yes. So John found his and wouldn't tell me until later. And when he finally told me, I kept watching it. And it was 2 or 3 months after I saw it and started changing colors. I said, okay, that's it. You don't have any more choices. And regretfully it was. But thank you all for coming tonight. The ones that have helped so diligently, our Tyndall Air Force Base lady was receiving treatment from my daughter, and my daughter promotes my breast cancer program. And she was telling Tammy about it, and Tammy said, I want to get involved. Tammy is a survivor also. And Tammy is the one that has purchased all of the beads, and her unit at Tyndall have made and put together all of the beads that we have to give out. So it's just been wonderful. And Dr. Miller that we met was the first one. Well, I knew Dr. Stokes. Dr. Stokes treated me in 2004. So we've been friends along the way. And he supported our Mariana Symposium all the way. But Dr. Miller was doing his biopsy after they had done the mammogram. And she come out to the car. She said, all your husband has talked about while I've been doing his biopsy is your symposiums. She said, we need this in Panama City. We don't have anything. And when I got to looking and thinking about it, all of the programs that they have here in Panama City that I have seen are fundraisers. I've got the doctors and others that have promoted this, Bakars, and I don't see Mr. Dotson here tonight with that, but they all thought we need this program. And it's educational all the way. Gulf Coast College, and the ones that have helped put this together tonight have all volunteered. This is something that just blew me away. I had to work in Mariana to get contributions to get it going. But we're starting this year, and as you see, it's first annual, and we intend for it to be more to come, and hopefully we'll get it together. This year has been a very organized year of trying to get it together. I was late getting started on it because I was taking care of John, and that was my priority, and I have no regrets for that part. So, John, you got anything you want to add? Who does not have a ticket?
I have a prize.
Should I give them to yeah.
Excuse me. No, I won't say but one or two things, and what I want to say is I'm blessed. Thank y'all. From the bottom of my heart.
Dr. Haberman did his chemo and his treatment with that, and of course Dr. Staples did his radiation here in town, so we're blessed. But we have a mixer and a blender for door prizes tonight. Both are pink.
The blender is too.
The blender is too. It doesn't show it, but it's supposed to be. Yes. So, Nisa, you want to draw?
Absolutely.
Which one are we going to draw for first?
Blender. The blender. Okay, we'll draw for the blender now. Get your tickets out. It's the red one.
I could not get tickets that had the double tickets, so I made it.
498-050.
All right.
We've seen several members tonight in their fatigues. These ladies are volunteering from Tennessee to help out tonight. The other students we have are from Miss Terry's class here at Gulf Coast, and we appreciate them so much.
And thank them for their service.
We never do enough to say thank you to our service members.
Who's got my name on here? 020. 498-020. We expect a lot of pink cupcakes out of this.
Plant giveaway to breast cancer survivors.
Okay.
Oh, the beautiful plants.
At each table, is there a breast cancer survivor sitting at each table?
That one and that one.
The breast cancer survivors get the plant they want on the table. All right. What about another cancer survivor of any kind sitting at your table?
Skin cancer.
You get the second one. All right. If you would like to pick up an extra box or two, please feel free to just carry them home. We don't want them wasted.
Who put together the pink swag bags? Because those are awesome. In October, our world is pink. That's your students?
Yes.
Thank you.
Dr. Stokes is here. Dr. Haberman is here. Do we have any more doctors besides?
Well, we got Dr. Miller.
Okay, Terry, you and yours.
Dr. Weintraut.
Thank you for coming. Thank you
Absolutely.
for supporting our program.
We have
But
the-
most of all, thank you for the work you do for each individual patient that you see. You are appreciated.
And we have the workers from Bay Radiology, technicians. Thank you for all you do.
Thank you for being here tonight.
Yes, thanks so much, everyone, for coming out tonight. And absolutely, breast cancer and cancer survivors, please do take a plant. If you want a floor plant, take a floor plant. We have plenty of them. And we do have an abundance of meals. So if you'd like to take some victuals home for loved ones or for tomorrow's lunch, please be my guest. And again, thank you so much to our sponsors, our speakers, and all of our volunteers, and our guests, and Lynette and John. Thank you so much for being the passion behind this. Thank you.